Namaste. Om Sahana Bhavatu Sahano Bhunaktu Sahaviryam Karvavahai Tejasvinavaditamastu Ma Vidvishavahai. Om Shanti Shanti Shanti. Dear students, we are going to discuss the anterior hip dislocation today. The incidence of anterior hip dislocation, this is a rare condition and is seen only 10 to 15% of the cases. In road traffic accident, when the knee strikes the dashboard with the thigh abducted, violent fall from the height, these are the causes. The forceful blow from the back of the patient in a squatted position. The mechanism of the anterior hip dislocation is due to the above forces. The neck of the femur or the greater trochanter impinges on the rim of the acetabulum, and through a tear in the anterior hip capsule, the head of the femur is levered out of the acetabulum, and that is how the anterior hip dislocation occurs. Now, if the hip is in simultaneous abduction, external rotation and flexion, and inferior type, that is obturator type of anterior dislocation of hip will occur. And on the contrary, if the hip is in abduction, external rotation and extension, rather than flexion, it is in extension, it results in a pubic or a iliac or superior type of anterior hip dislocation. Now, there could be associated fracture of the head of the femur. The classification wise, the anterior hip dislocation is classified using a comprehensive classification, and this is the same as for what we have utilized in the posterior dislocation of the hip discussed in my previous videos. As far as the Epstein's classification is concerned, the anterior hip dislocation is type 1. There is a superior dislocation including the pubic or the subspinous dislocation. That is the head of the femur lying on the pubic bone or lying just below the anterior superior iliac spine. Now, in type 1A, there will be no associated fracture. That means it is a simple anterior dislocation. Then type B, it is associated fracture of the head, maybe a transcondylar fracture or an indentation type fracture, and or the fracture neck of the femur. And type 1C, there is an associated fracture of the acetabulum as well. The type 2 is the inferior type of dislocation and dislocation, which includes the obturator or the thyroid or the perineal dislocation. Now, type 2A, again, it is not associated with any fracture, that is a simple dislocation, anterior type of inferior dislocation. Type 2B associated with the fracture of head, which may be again the transcondylar or the just a indentation type, and or the fracture neck of the femur. Type 2C, it is associated with the fractures of the acetabulum. Coming to the clinical features, the multi-system injury is a possibility. You must always remember, because the force required to bring out the head of the femur out of the acetabulum is enormous, and obviously that enormous force may be a cause for the multi-system injury as well, and hence it has to be carefully evaluated. The position of the limb suggests the diagnosis. In the superior type, that is the iliac or the pubic type, the hip is extended, externally rotated, and the head is felt near the anterior superior iliac spine in the iliac type, or in the groin in the pubic type. In the inferior type, or the obturator or thyroid or the perineal type, here the hip is abducted, externally rotated, and in varying degrees of flexion. Now, head is palpable in the region of obturator foramen. Distal neurovascular status has to be assessed due to the possibility of injuries to the femoral vessels and nerves. The investigation wise, the X-ray is most important investigation. Diagnosis can be easily made on the plain X-ray. We have to look for any associated damage to the femoral head, neck, etc. The CT scan, this helps to detect the intra-articular fragments, if any, and also helps to evaluate the femoral head and the acetabulum. CT scan is also indicated after the close reduction, or if the close reduction fails before doing or going for the open reduction. Now, MRI scan in the anterior hip dislocation, this helps to evaluate the integrity of labrum, vascularity of the femoral head, and the osteochondral lesion, if any. It has a definite role in these cases of unstable hip after the dislocation, or in the widened joint space after the reduction. Coming to the treatment part of the anterior hip dislocation, we should remember the goal is prompt diagnosis and immediate close reduction under general anesthesia. Caution: the single and not multiple, single attempt is advised, failure of which warrants open reduction at the earliest. Now again, the methods, various methods can be remembered using a mnemonic ABCDEs. That is, A stands for Alice method. This is the same as for what we have described for the posterior dislocation. B stands for Bigelow's method. Actually, this is the reverse Bigelow. Here the hip is in the partial flexion and abduction. And here described two methods. The traction method. Here the traction is applied in the line of deformity and the hip is adducted, internally rotated and then extended. The lifting method, second, here the flexed thigh is lifted and with a sudden jump. And however, the method is not successful in pubic type of dislocation. Classical Watson-Jones method. Now this is the same as described previously in the posterior dislocation of the hip. Now the Dilly and Epstein method has been described, and this is a modified Alice technique, and it consists of the continuous traction in the line of deformity, hip in the slight flexion, lateral force to the thigh with the slight internal rotation and adduction is applied, and the hip gets reduced. The Stimson's gravity method, same as for the posterior dislocation. However, it is not useful for the superior type of dislocation, as the hip here is in the extended position. Now the post-reduction X-ray evaluation must be done. A careful X-ray evaluation is a must after the close reduction. Here we have to look for any associated transchondral fractures, the femoral neck or the head fractures. A transchondral fracture needs excision, open reduction and internal fixation. For the large fracture of the femoral head is also required, and indentation fracture, they need to be left alone. Now the post-reduction protocol is traction for a period of 1 to 6 weeks. Controlled range of movement is instituted during the traction. Avoid extremes of abduction and external rotation. If there are associated fractures, the longer period of immobilization are required, and these are the immediate complications include the neurovascular compromise. Most important, in the superior and open dislocation, there could be pressure on the femoral artery, vein and nerve, leading to distal neurovascular compromise, and it warrants immediate reduction of the hip dislocation. The second complication is irreducibility. Now these could be due to following reason. 1. Bony block in the obturator foramen. 2. It could be soft tissue interposition, maybe from the rectus femoris or the iliopsoas muscle or the anterior capsule. Now this will always necessitate the open reduction. The post-traumatic arthritis, the third delayed complication. This is reported in more than 1/3 to 1/2 of the cases, and the reasons could be 1. The femoral head fractures. 2. The acetabular fractures. 3. Avascular necrosis. 4. Transchondral and indentation fractures of the femoral head. Now the incidence is 8%, less common in the posterior dislocation. It is more common in it is more common in the posterior dislocation, and it is less in the anterior dislocation. Now it may appear 2 to 5 years later. The reasons could be due to the delay or repeated attempts at reduction. The extent of the initial injury has an important role. The defective capsular healing due to inadequate immobilization could lead to another complication, that is recurrent dislocation. Now another complication is unreduced dislocation, commonly seen in the developing conditions or countries than the developed conditions. The 3 methods of treatment are advised for the unreduced dislocation. First is open reduction. Now this could lead to painful hip at a later stage. Second is osteotomy of the proximal femur, and this has been tried with varying results. And third thing is total hip replacement in late cases. Now coming to the second topic for discussion today, the central hip dislocation. This is the least common but the most difficult of all dislocations of the hip joint. Now, mechanism of injury, it could be due to the direct blow on the greater trochanter, as in the case of a road traffic accident, or somebody, as you can see in this particular diagram, somebody getting sandwiched between the 2 vehicles, or fall from height on the sides. Now, it is invariably associated with the fracture of acetabulum, and this is what makes it a very difficult problem to treat. The classification, Judet has classified it: undisplaced fractures, either single line or a stellate type, or the inner wall fracture. Of course, this classification is based on the fracture of acetabulum. The inner wall fractures, the femoral head concentrically reduced beneath the dome on the initial X-rays, or the femoral head not reduced under the acetabular dome but centrally dislocated. Then superior dome fractures, the gross outline of the acetabular dome intact and congruous with the femoral head. Then there could be gross outline of the acetabular dome not intact and not congruous with the femoral head. Then a bursting type of fracture, all elements of the acetabulum are involved. The fracture in which the congruity remains between the femoral head and the acetabular dome. Fractures in which there is a congruity between the femoral head and the acetabular dome. And interestingly, when it comes to the clinical features, there is no such feature as seen in the anterior dislocation of the hip or posterior dislocation of the hip. On the other hand, in the central dislocation of hip, there is no limb shortening or very minimal limb shortening. No external rotation deformity, no internal rotation deformity, head is externally not palpable. The limb is in the neutral position, there is pain and severe restriction of the hip movements, and a huge bruise on the greater trochanter. Now, head is felt easily by a per rectal examination, and hence whenever you are suspecting that patient has got the central type of hip dislocation, you must not forget for doing a PR examination, per rectal examination. Coming to the investigation, X-ray evaluation is most important. Plain X-ray plays a very important role in the diagnosis of these injuries. The recommended views are the AP view of the pelvis with both hip joint, and then internal and external oblique views as suggested by Judet. Now the X-ray pelvis, that is the formal view, helps in demonstration of the femoral head and acetabular relationship, while The later, that is the Judet's view, help in delineating the fracture line and the displacement. The CT scans, this helps to delineate the fracture lines better and with far more greater accuracy than the plain X-rays. MRI scan, this helps to study the vascularity of the femoral head and the bony and cartilage architecture. Coming to the treatment part, reduction of the dislocation assumes lots of clinical importance as it is essential to obtain as accurate reduction as possible to restore the acetabular congruity. Now this will prevent the post-traumatic osteoarthritis. Reduction is achieved through the skeletal traction over the greater trochanter in the line of neck of the femur. Now open reduction is reserved for cases of failed closed reduction. The skeletal traction is maintained for 10 to 12 weeks if the acetabulum is reasonably reconstructed. Now if the reconstruction of the acetabulum is far from satisfactory, after the mandatory skeletal traction, then open reduction and surgical reconstruction of the acetabulum is recommended. Now there is a role of primary arthroplasty and arthrodesis as well. Now this is recommended in extreme cases where the closed reduction fails and open reduction reveals severe articular damage. The early complications include the sciatic nerve palsy. The sciatic nerve passes out of the pelvis through the greater sciatic nerve, and hence the central dislocation may again damage the sciatic nerve here, and along with that it may also damage the superior gluteal artery, and it may lead to thrombophlebitis and the bowel obstruction. There could be aseptic necrosis of the femoral head, the pin track infection because of that central pin traction plate we are putting in the neck of the femur, and recurrent central dislocation. The post-traumatic osteoarthritis is an escapable complication in the central dislocation if you manage it in urgent basis, reducing the acetabular cavity properly. Then the other fearful complications include myositis ossificans as shown in this particular X-ray, the avascular necrosis of the femoral head, and stiff and disabling hip. With this we conclude our discussion on central hip dislocation. However, before we end, I want to talk to you about one more topic, and that is happy key to lose weight. Dear students, one of the commonest problems we are facing in our routine clinical practice is of obesity. Now, eat less and exercise more formula for treating obesity has been proved to be the failed formula. Of late, I have been working on the latest, most scientific, evidence-based concept of weight loss, happy key. You may find various videos on this topic as well on my YouTube channel. The obesity among the medical student is at its peak nowadays. Due to obesity, not only they are bullied, but most of them also lose their self-confidence, resulting in deteriorating performance in academics. For all of them, this online video course will be most valuable. If interested, you may visit my Facebook page on given address and the website www.drorthosudhir.com. Now, for details of this course, I recommend you to watch my above mentioned video completely. Now you can enroll for the course as well. You may forward this video to others. The link for this particular video, YouTube video, is https://youtube.b/mlx_AAR4. My mission is to help more than 10 lakh persons to lose weight and get lifetime freedom from their obesity without dieting and exercises using this happy key technique. Let all of us come together to create a healthy and fit India. Please do like and subscribe my channel. Do recommend it to your friends in other medical colleges as well. Your recommendation has a lot of value. Please help me help all medical students all over the country. That would be my Guru Dakshina from you all. Thank you. Thank you for patient listening. See you in the next video.